Olá pessoal, meu nome é Guilherme Perini, eu sou médico hematologista do Hospital Israelita Albert Einstein e head da hematologia do Grupo Américas em São Paulo. E hoje a gente vai ter o privilégio de ter dois grandes experts em LLC para a gente discutir alguns assuntos que são bastante relevantes. Primeiro eu gostaria de, obviamente, agradecer a ABHH por esse meeting, por esse encontro que a gente está tendo, e também a Abbvie, que também é um dos apoiadores deste evento. Então, a ideia, o evento, ele vai ser baseado em duas aulas e depois a gente vai ter um tempo para discussão. Vocês podem mandar as perguntas, eu vou fazer questão de tentar passar o máximo de perguntas para os nossos palestrantes e também, obviamente, isso dá mais vida no nosso encontro, a gente consegue, então, aproveitar melhor os nossos palestrantes. Sloan Kettering, em Nova York, um dos grandes pesquisadores de LLC no mundo atual, tanto do ponto de vista de novas drogas, como de dados de mundo real, para ele falar um pouco para a gente sobre os destaques que a gente teve em LLC no ano de 2020. Dr. Mato, if you want to go with your slides, feel free.
Thank you very much for the opportunity to be here and to meet with your group. I wish we could be together, which would be very nice. But a lot of things happened at the ASH meeting and in 2020 that I wanted to share with you, and hopefully this will give us opportunity for having a conversation. I'm just trying to share my screen.
Okay.
So I'm going to talk about emerging agents and combinations in CLL. These are my disclosures, and I'm always interested in history. And in CLL, you can see that there's been tremendous progress between 1950 and the present time, where we started off with just the basics, glucocorticoids and alkylating agents in the 1950s, and then the introduction of CLL staging systems, which helped us to organize patients quite better, the introduction of nucleoside analogs, and then, of course, the key trials looking at combination chemotherapy versus single-agent chemotherapy, the era of chemoimmunotherapy, but most importantly, and our focus today is the era of targeted therapies, where since 2014, we've had several targeted agents approved, which have not only improved patient quality of life, but demonstrated improvements in progression-free and overall survival, and have really demonstrated improved activity over the current standard or over the previous standards of care, with the pinnacle being ibrutinib-based therapy being better than FCR. It's really a pleasure to take care of patients with CLL. It's a pleasure to be involved in clinical research because every day we're introducing new molecules in the clinic where patients are having tremendous benefit, and we're seeing patients living longer and benefiting from the research that we're doing. And so today I'd like to talk about some of the achievements that were made over the last 1 to 2 years in the area of CLL. And this is just a reminder of what the general targets are, including the microenvironment, B-cell receptor signaling, cell surface targets, and then the cell death machinery, specifically BCL2. So where are we in 2021? Well, in the frontline setting, the trials that I want to mention include the CLL14 trial, which I'll update, the Captivate trial, looking at MRD-based decision-making, the AVO regimen and the Bovin regimen, how BTK inhibitors are being studied in patients with poor risk disease, the Sequoia update looking specifically at patients with deletion 17p, and then in the relapse refractory setting, the update of the Murano trial, the update of the U2 study, a new molecule that we've really been involved with at Memorial Sloan Kettering, LOXO 305, CAR T studies, and then a new novel triple combination therapy for patients with Richter's transformation. And so the way I've organized this is to look at patients treated in the frontline setting and then in the relapse refractory setting. And I wanted to start with the CLL14 trial, which is a really important trial, which has changed the standard of care in the US for how we manage patients. This is a trial that was conducted by the German CLL study group, randomized trial. Patients generally were unfit with a SEER score greater than 6, looking at a fixed duration of venetoclax with obinutuzumab for a total of 1 year, 6 months of overlapping therapy, and 6 months of venetoclax monotherapy, randomized against the CLL 11 regimen, which is chlorambucil obinutuzumab, with a slight tweak in the regimen where patients received chlorambucil for a total of 1 year in total. And the primary endpoint of the study was progression-free survival. Key secondary endpoints included response, MRD, and overall survival. And this is the key endpoint of the trial. This is progression-free survival. Here we have a median of 39.6 months, and you can see the median PFS for ven-obin was not reached, but was 35.6 months for chlorambucil obinutuzumab. The 3-year PFS rates were 81.9% versus 49.5%. That resulted in a hazard ratio of 0.31 with a p-value of less than 0.0001. So overwhelmingly positive for progression-free survival. One question that you have to ask from this trial is, where did 12 months come from? We know venetoclax used in the relapsed refractory setting is used for either as a continuous therapy, as a monotherapy, or in combination with rituximab for 24 months. And so we do have some interesting data looking at clonal dynamics after the obin venetoclax combination. And what we learn is that at least 50% of patients had what we call negative growth, meaning they probably were continuing to respond to venetoclax therapy at the time that they discontinued, which to me suggests that it should not be a one-size-fits-all strategy using this molecule, and that 12 months fixed duration is probably appropriate for most patients, but there are some that would potentially benefit from longer therapy. And at our center, we're actually conducting a clinical trial with the same regimen, except for patients who have persistent disease at 12 months, they continue on venetoclax for an additional year to try to improve and further deepen that response. Overall, the MRD between the arms was markedly different. You can see it was 74% for the ven-G at the end of therapy and only 32%. Well, I should say impressively 32% for the G chlorambucil. Those were statistically significantly different. And the depth of remission beyond 10 to the minus fourth was also markedly different between those arms. We also got four-year follow-up on key endpoints, including PFS, OS, and time to next treatment. Here you can see in the first curve, the 4-year PFS rates were 74% versus 35.4%. The median time to next therapy at 4 years was 81% versus 59%. And so what we start to learn is that there are differences in progression between these arms, and you can start to see asymptomatic progressions more frequently in the venetoclax-based therapy, but no difference in overall survival. And so the updated summary for this study included that the study demonstrated that individual clonal growth rates can be used to estimate MRD doubling after a fixed duration treatment. I didn't show that, but essentially very important that we're starting to use MRD kinetics to start to look at when these patients will actually progress clinically. Clonal growth was slower after ven-G as compared to chlorambucil G, so not all MRD is created equally, and the clone just grows back slower after the ven-G based therapy. And there was a small subset of patients here where there was no clonal growth measurable during this period of time, really raising the question whether or not some patients were cured. The next trial I wanted to talk about was also highlighted at the ASH meeting with several times in the past as well, the Captivate trial. And this is looking at the combination of ibrutinib plus venetoclax in the frontline setting. And here, this trial is really one of the first aimed at MRD-driven decision-making. The way the trial was designed was everybody gets 3 months of ibrutinib, then everyone gets 12 months of ibrutinib and venetoclax in combination, and then there are some randomizations based on MRD status. For patients who are undetectable for MRD at a sensitivity of 10 to the minus fourth after that 15 months of therapy, they're randomized to receive placebo versus ibrutinib. For patients who were detectable, they're randomized to receive ibrutinib versus ibrutinib plus ven, so essentially continuing on the current therapy. The primary endpoint was 1 year disease-free survival in the confirmed undetectable patients. And you could argue maybe that's a little bit too short to really detect a difference, kind of an unusual primary endpoint. You can see the patients who participated in the trial stratified between the two arms based on MRD status, and then in terms of the randomization. relatively standard risk patient population in terms of the high-risk features and who would have participated, younger than the average CLL patient population. You can see the 1-year disease-free survival after randomization in patients with confirmed undetectable residual disease. The yellow or the orange curve is ibrutinib versus the gray curve was placebo. The 1-year DFS, disease-free survival rate, was 95 versus 100%, but those were not statistically significantly different. And so one conclusion here was that after 15 months of therapy, at least at this primary endpoint, there was no difference in outcome, strongly supporting the rationale to discontinue ibrutinib at that time point. The other thing we learned from the other group of patients, those who were MRD positive and either continued ibrutinib versus ibrutinib and venetoclax, was that the only patients who continued to benefit in terms of deepening of response were the patients who received the venetoclax, the ongoing venetoclax-based therapy. So it does argue again for something I mentioned earlier from the CLL14 trial, that we probably should be thinking about MRD-based decision-making rather than just a fixed duration for everybody, because some patients may continue to benefit from deepening of the response by continuing the venetoclax-based therapy. I don't know if people from industry are on this call, but definitely one of the most confusing AE assessments I've ever seen presented at a meeting. Here we're looking at the AEs at different time points across the arms. And the general take home from this was that the AE profile for the combination was well tolerated. If any events happened, they tended to be relatively early events. And with later or longer term follow-up, there was no new safety signals that emerged over time. So the conclusion from the presenters was that this is an all-oral regimen, chemotherapy-free, potentially fixed duration schedule that resulted in deep remissions. And so there is a GLOW trial that's ongoing or was completed but not reported, looking at the combination of ibrutinib plus venetoclax plus chlorambucil obinutuzumab. I can tell you the results of that trial will be that the combination will be better than the obinutuzumab chlorambucil, no surprise, and that will potentially lead to a new standard of care. I now want to shift gears and actually talk about MRD-based decision-making with two different regimens that have been presented at multiple meetings. This is the Bovin regimen, which is actually an MSK study in partnership with Mass General. Dr. Thompson and I have taken care of many patients on this trial. This is the triple combination of zanubrutinib, obinutuzumab, and venetoclax in treatment-naive CLL. And so here's the study design. Patients receive a 2-cycle lead-in of zanubrutinib, which is a BTK inhibitor with obinutuzumab, and then venetoclax dose escalation is introduced. Patients receive ongoing therapy and have sequential MRD assessments. And if patients have confirmed MRD at a level of 10 to the minus fourth at 2 endpoints, they're able to discontinue therapy. The primary endpoint was the frequency of undetectable residual disease confirmed in the peripheral blood and the bone marrow, but secondary endpoints included time on therapy to achieve undetectable disease, as well as safety and tolerability. To participate in this study, there were just basically a general treatment-naive CLL population who required therapy as per IWCLL criteria. And at the time this data were presented, there were 39 patients who participated. Median age was 59. Generally a high-risk patient population where you can see the CLL IPI listed there. This is the primary endpoint, and you can see the best MRD in the bone marrow and peripheral blood were pretty highly correlated between 89 and 90, essentially 92%. You can see MRD approved sequentially over time with the combination, and per IWCLL response criteria, the best response for CRs were 54.1%, but the overall response rate was 100%. And 89.2% had achieved undetectable residual disease in the peripheral blood and the bone marrow and were able to stop therapy after a median of only 10 months of exposure, 8 months of exposure of the triple. This is the swimmer's plot. Orange represents time on therapy. Blue represents surveillance with ongoing MRD response assessment. So it's very obvious that essentially all patients have stopped there, or nearly all patients have stopped therapy at the time of this presentation as a result of deep responses based on sequential MRD testing. The combination was well tolerated. Hematologic events were the most common adverse events, but I can tell you from my own personal experience that this combination was incredibly well tolerated. A competing regimen or a similar regimen is the AVO regimen, acalabrutinib, another BTK inhibitor combined with venetoclax and obinutuzumab, which was presented by my friend Matt Davids. This is a Dana-Farber study where a little bit of a different design. There's different lead-ins where you start with acalabrutinib, then you introduce obinutuzumab, then you introduce venetoclax, and then you do response assessments over time, where at the cycle 16 response assessments, patients are eligible to discontinue if they're MRD undetectable, and I believe in complete remission. What's a little bit different about this study is they enriched it for poor risk features, and so you can see 38.6% of patients had at least one TP53 aberrancy. The regimen was well tolerated, again, with hematologic toxicities probably largely attributable to the venetoclax as the most common AE. And then they did present nicely the debulking strategy of using acala-obin prior to venetoclax, where you can see 30% of patients were high risk, 64% of patients were medium risk, but it led to 91% of patients being low risk for TLS at the time venetoclax was started. You can see the IWCLL response, essentially 100% in all patients, even in the TP53 aberrant patients. MRD data are quite impressive, even in the TP53 aberrant patient population. And at the time of the presentation, 11 patients had a CR with undetectable residual disease after 15 cycles and were able to discontinue, with no patient progressing or having recurrent MRD to date. Now I want to focus a little bit more on deletion 17p, and this is the Sequoia trial, zanubrutinib monotherapy, arm C, and these are patients with the del 17p. And for the other companies that make BTK inhibitors, there has been a woeful absence of study of BTK inhibitors in the frontline setting in patients with the deletion 17p. Ibrutinib hasn't done it. Acalabrutinib has barely done it. Here we see zanubrutinib being studied in 109 patients, definitely the largest subset of patients with the del 17p in the frontline setting, and we got a chance to look at those outcomes. And they're really interesting. The overall response rate was 94.5%, so incredibly active, 5.5% or a little bit over 6% if you count the CRIs being in CR. And you can see here the 18-month PFS was 90.6%. Overall survival was excellent at 95.4%. Clearly, targeted therapies are the standard of care when we're thinking about patients with TP53 abnormalities. And this is the largest prospective data set to support the use of BTK inhibitors in this particular patient population. Zanu was well tolerated, it was active, and it resulted in really durable remissions. And so that was the conclusion here. Nothing different from what we do in practice, but nice to see a large prospective data set supporting the use of this class in this particular high-risk feature. Now I want to switch to relapse refractory disease and jump into the Murano trial, which was presented. 389 patients, randomized trial of BR, bendamustine rituximab, given for 6 months in the relapse refractory setting, not something we commonly do, versus Ven-R, given for a total of 24 months, with the primary endpoint being progression-free survival. And so this is the 5-year analysis where we see that the median PFS has been reached for both arms, 17 months in the control, 53.6 months in the experimental arm, overwhelmingly positive for PFS with a hazard ratio of 0.19. A little bit of a surprise also, overall survival benefit. You can see here the hazard ratio was 0.40 at 60 months, 82 versus 62% of patients. They've also started to look at prognostic factors and how that translates into MRD and conversion to detectable disease, and then conversion to subsequent progression. And to summarize this complicated table, the bottom line is that patients with deletion 17p, complex karyotype, and IGHV unmutated disease tend to have less of a chance of developing undetectable disease, a higher rate of conversion to MRD, and a higher rate of conversion to progression of disease. Very important to note that some of the older standard prognostic features that were born from the chemoimmunotherapy era have borne out as important prognostic features for patients treated with Ven-R in this study. We also got a window into time from end of therapy at 24 months to MRD conversion. The median was 19.4 months. And then the time from MRD conversion to progression of disease, so the next step forward, was 25.2 months. No new safety signals. There's a smattering of patients who have progressed and gone on to receive venetoclax again. And so this will give us some window into the future about ven retreatment as a strategy following a fixed duration venetoclax schedule. I also want to talk about the Unity CLL study, and I had a hard time deciding whether I should include this in the frontline or the relapse refractory section because it's a weird study design. This is a randomized trial, one-to-one randomization of the PI3K inhibitor umbralisib combined with ublituximab, a CD20 antibody, versus G-chlorambucil. And to participate in this trial, you could have had treatment naive or relapse refractory disease requiring treatment per IWCLL criteria. So it was a weird combined frontline relapse refractory registration trial with the primary endpoint being progression-free survival. This was the primary endpoint. The median PFS was reached for both arms. U2 was better than G-chlorambucil, 31.9 months versus 17.9 months. The hazard ratio was 0.54. It was a positive trial. The 2-year PFS was 60.8 months versus 40.4 months. So a positive study, better PFS, better response rate. AE profile looked interesting in that it might have been, this molecule might be better tolerated than other PI3K inhibitors, particularly when we think about the fact that it was used in the frontline setting where other PI3K inhibitors have not made the cut. They've been too toxic, like idelalisib. But you do see some of the same adverse events associated with other PI3K inhibitors, including transaminitis, pneumonitis, colitis, and opportunistic infections. I next want to talk about next generation BTK inhibitors with a focus on the reversible or non-covalent inhibitors. And this is data that we presented on behalf of many investigators from around the world on LOXO 305, which is the next generation highly selective non-covalent BTK inhibitor. I haven't talked about it already, but the major problem with the covalent BTK inhibitors are discontinuations due to intolerance and also progression of disease. If you look at the ibrutinib data at 5 years in the frontline setting, 41% discontinue. In the relapse refractory setting, 54% discontinue. And when you think about resistance, the most common mechanism of resistance are BTK CYS481 mutations. So it would make sense to think about using a non-covalent inhibitor, which would bind differently, it would have a different binding mode to potentially allow continued targeting of BTK for patients with relapse refractory disease. So LOXO 305 was designed with that intent. It's a non-covalent inhibitor, it's highly selective, it's incredibly active, and preclinical data really supported the fact that it would be active in CYS481 mutant CLL. And so we conducted the phase 1, phase 2 trial, and I presented data on 170 patients with CLL who got LOXO 305 from many centers. 86% had a prior BTK inhibitor, but you can see the median number of prior therapies here was high. Overall 3, 4 if you had a prior BTK inhibitor. And then the reason for discontinuation of the prior BTK inhibitor was progression of disease in 67%. You can also see from the slides that about 27% had that BTK CYS481 mutation. So probably that is important, but it's not telling the entire story of BTK inhibitor resistance. One of the most important highlights from this trial was the adverse event profile. Very well tolerated molecule, very few grade 3, 4 events, less than 1% AFib, less than 1% major bleeding, not a lot of discontinuations due to adverse event, only 1.5%, leading to a 200 milligram per day dose selected as the recommended phase 2 dose. The waterfall plot says a lot. You can see nearly all patients had a universal reduction in lymphadenopathy. The blue bars represent BTK exposed patients. The stars represent CYS481 mutant disease. The hash marks represent prior BCL2 inhibitor. Very active. Response rate was 63%, but for the subset of patients who had longer term follow-up, by 10 months, it went up to 86%. And you can see here the responses were durable. Median follow-up is 6 months. But 94% of patients at the time of presentation were remaining on therapy with only 5 discontinuations, 4 for progression, 1 for an elective allotransplant. And then even in patients who had failed 5 prior therapies, like a BTK inhibitor, BCL2 inhibitor, PI3K inhibitor, chemotherapy, and a CD20 inhibitor, the responses were maintained. So regardless of prior therapy, reason for BTK inhibitor discontinuation, or mutation status, the drug was active, resulting with relatively short follow-up and a good duration of response and progression-free survival. I want to briefly delve into the data for CAR-T. Certainly still an experimental therapy, not approved in the United States. And these data sets are very small, non-randomized data sets for highly selected patients. So keep that in mind. But with that said, Tanya Siddiqui presented some data on a high-risk patient population looking at the lysocaptogene cellular product, specifically in patients who had a prior BTK inhibitor and a large subset of patients, or rather a small subset of patients who had both a BTK inhibitor and venetoclax, with the summary being a response rate that was 82%, median PFS of 13 months, relatively well tolerated. But interestingly, 4 of 6 progression events were due to Richter's transformation. Bill Weirda looked at 19 patients, and here he decided to go down the road of combination therapy with a BTK inhibitor with the proposal that it might enhance T cell collection and activity. 19 patients, so tiny number, again, highly selective, but the response rate was 95% with 63% CRs and MRD negativity in the bone marrow of approximately 80%. Finally, we presented a new triple combination therapy for Richter's transformation at the ASH meeting. Of course, a little background about Richter's. It's an awful complication of CLL occurring in 5 to 7% of patients with a survival that across all series is less than 1 year. Here we put together a triple combination therapy of a BTK inhibitor with pomalidomide and everolimus. The BTK inhibitor was called DTRM12. So 3 different pathways hit simultaneously with the thought that that might have almost a synthetic lethality approach to hitting multiple pathways to kill cells. And this approach was supported by preclinical data. Here you can see the green curve of the triple combination in a DLBCL cell line, really supporting introduction for this combination to patients. This is a study. It was a phase 1, 3x3 design where patients first got BTK inhibitor monotherapy, then the next group got combination of double therapy, and then the next group got the triple therapy. Small numbers here, so I don't want to claim too much. 13 Richter's patients, 11 DLBCL patients separately participated in the study, very heavily pretreated. Most patients had received prior BTK inhibitors with Richter's or prior chemoimmunotherapy. The combination was relatively well tolerated, with hematologic adverse events being the most common event. But you can see the response rate was generally impressive at 46% for Richter's. Here we see the waterfall plot. 43% of patients had at least a greater than 50% reduction in lymph node area. 71% of patients had any reduction in lymph node area. The swimmer's plot for Richter's is highlighted on top. Again, small numbers, but several patients had durable remissions. And then we focused on the small number of Richter's responders here, high number of prior therapies, and then focused on imaging, where you can see from this particular patient who had received everything, including rituximab, ibrutinib, venetoclax, R-CHOP, obinutuzumab. When they finally received this combination called DTRM555, they had a marked improvement on their PET scan, here presented as cycle 5. So in conclusion, in the frontline setting from CLL14, Ven/Obin provided durable benefit for most patients, excellent 4-year PFS. Clonal dynamics and MRD improve our understanding and guide the next generation of studies. Captivate was ibrutinib plus venetoclax, very effective, active. MRD can be used to guide decision-making, and all future studies should include that. We saw 2 early triple combination therapies, AVO and Bovin, well-tolerated, active, unique designs in terms of MRD-driven decision-making, and the Sequoia trial where Zanu looked great in del17p CLL. In the relapse refractory setting, we saw the update for Murano, where we now have a median PFS for Ven/R. We saw different clonal dynamics based on the prognostic evaluation for patients. Patients with L17P, unmutated IGHV, or genetic complexity did worse. U2 resulted in a positive trial, both in the frontline and relapse refractory setting. Maybe umbralisib is the new PI3K inhibitor to beat. The Bruin trial was LOXO 305, looks to be incredibly active, certainly may fill an important gap for BTK mutated patients. We saw the CAR T data, which look encouraging, but still too early for introduction into clinical practice. And the DTRM molecule or combination was well tolerated and active in Richter's, supporting a synthetic lethality concept. And so with that being said, I really thank you for paying attention. I know this is a long presentation, but looking forward to hearing from Dr. Thompson and for further conversation about the data that I presented.
Thank you, Dr. Mato. I'll invite Dr. Thompson to talk about the importance of real-world evidence in patients with CLL. Thank you, Dr. Thompson.
Thank you. Thank you all for the opportunity to talk today about real-world evidence in patients with CLL. So let's start by defining what we mean by real-world evidence. So this is evidence collected outside of conventional clinical trials that can be used to understand many factors, including burden of illness, treatment patterns of practitioners, patient patterns, and also drug efficacy in settings and populations that are representative of the patients we see in routine clinical practice. And real-world data really is being increasingly utilized to make clinical decisions, particularly for questions that aren't answered by clinical trials. And also regulatory bodies and payers are paying attention to this data to support approvals. So why is this evidence important? Well, we all know that clinical trials, particularly randomized clinical trials, are important, but often not enough to treat patients seen under the conditions that we actually use these agents and need to treat patients. And so there's some important benefits to highlight of real-world evidence. Often these studies can be more representative of the patient populations we see in everyday clinical practice. Large samples can be used, and we can include patients, particularly patient populations who are excluded from clinical trials. There's more comparisons that we can make. So as we know, control arms of trials often aren't head-to-head, particularly in CLL, of the therapies that we're considering in the era of novel agents. We're able to identify new adverse events in these particular patient populations. And there's important financial and economic data that we can gain as well. These studies can be less expensive to conduct than clinical trials, and results can be faster. So this can help fill important gaps needed for our patients. There's limitations of real-world evidence that we should bear in mind, particularly during this presentation. There's potential for bias that can come from diversity of real-world sources. Real-world data sources might not represent, the overall patient population. It depends how data is collected, the quality and the integrity of the data, and there could be a lack of standardization across data sources. And it can be a challenge to really go through this data, see what purposes the data were originally collected for, and see if they can be combined and or compared. And there can be some global variation of real-world data. While it's a strength that we might be able to identify global variation in practice patterns, it can be difficult to generate real-world data specific to certain populations, depending on the healthcare system. So this slide just highlights the emerging role of real-world evidence. You'll see that Ibrance for breast cancer in males who were excluded from the Paloma trials that led to the approval in breast cancer for Ibrance. And then more recently with COVID vaccination, there's been several reports reporting beyond the clinical trials for COVID vaccines that have come out and begun to garner a lot of attention. So real-world evidence in CLL is growing in importance. There's been many studies, and we'll address some of them today. So as you heard from Dr. Mato, the past couple years have been exciting, but really the past decade, we've had several novel agents that have really transformed treatment for CLL, and we are hearing about even more coming out and coming through the pipeline. And this has really created new challenges on how to best sequence these therapies, which patient populations are appropriate for which agents, and how we can combine these therapies. And with new agents comes new toxicities. And so management of toxicities is important to look at, as well as patients who may have progressed on all of these agents and might not fit the bill for clinical trials of the original studies. So as we already mentioned, we can address important unanswered questions, including head-to-head comparisons of novel agents, longer follow-up, and really sequencing data, as we'll highlight in this presentation, is informed by these retrospective studies. So let's first talk about testing, performing appropriate testing to guide therapy. And real-world data has really been able to shed some light on this topic. So this has been deemed the age of personalized medicine. And we've seen some of that in CLL, where therapy selection can be based on molecular and genetic disease profiles. And we do have guidelines, IWCLL guidelines, national guidelines from different societies in the US, the NCCN guidelines. And there are major differences between what is recommended in the guidelines and the testing that's actually being done in clinical practice. So this just summarizes the IWCLL guidelines and what testing is required prior to therapy initiation. You can see at the bottom. And this includes, I'm just going to highlight IGHV mutational status, TP53 mutation by DNA sequencing, as well as FISH testing for deletion of 17p. And real-world data has been used to, shed light on these practices. So this is the CONNECT CLL registry, which looked at a prospective cohort study of many CLL patients and almost 200 US centers. And this showed that FISH testing was only performed in 65% of patients, and retesting at the next line of therapy was only performed in 36% of patients. And so this was published back in 2016, so a lot of these patients were receiving chemoimmunotherapy prior to novel agents really taking hold. And so real world data, you might say, well, maybe things have improved in the era of novel agents. But this is data from the Informed CLL Prospective Registry presented in December at the ASH meeting, and showed that standard testing is still not consistently performed. And so just to highlight some of the testing findings that are highlighted up here with the FISH, TP53, and IGHV testing, only 28% of patients had FISH. For patients with TP53 mutation, only 11% of patients had testing, and IGHV mutational status testing in 12% of patients. So even when testing was performed, the practice patterns didn't always fit the guidelines. So 28% of patients with deletion of 17p received chemoimmunotherapy, 21% of patients with a TP53 mutation received chemoimmunotherapy, and 39% of patients with unmutated IGHV received chemoimmunotherapy rather than a novel agent as suggested by the guidelines. So now we'll shift gears and talk about ibrutinib, some data from real-world trials that fills the gaps of clinical trials. So here you'll see data from the RESONATE-2 study, and this included patients greater than 65 years old with ibrutinib for initial therapy, but importantly, all patients did not have deletion of 17p. So this is a real-world study led by Dr. Mato, looking at outcomes for frontline ibrutinib-treated patients excluded from this landmark clinical trial. And importantly, just to highlight, it included patients less than 65 years of age, as well as patients with TP53 mutation or deletion of 17p. And the PFS and OS were inferior in these deletion 17p ibrutinib-treated patients in the frontline setting. And the PFS and OS were similar when the ibrutinib-treated patients were stratified by age. And so those important outcomes, shed light on how ibrutinib performs in patients that weren't included in the clinical trials. Importantly, atrial fibrillation and pneumonitis were two toxicities that really emerged in clinical practice, and the real-world evidence highlighted these. So just to look at in general, two different real-world study papers of CLL patients who were treated with ibrutinib in clinical practice. And in these studies, toxicity was actually the most common reason for ibrutinib discontinuation in both the frontline and relapse refractory settings. This is a super important finding because in the early follow-up of clinical trials of ibrutinib, disease progression was more common than toxicity. But really with this real-world data, we saw that in clinical practice, in a different patient population, a real-world patient population, that more patients were discontinuing for adverse events. This is a report of ibrutinib-induced pneumonitis in several patients, and this is a toxicity that really came up after the initial trials of ibrutinib. And then this is a paper looking at baseline left atrial abnormality, and that was shown to predict ibrutinib-associated atrial fibrillation. So shifting gears from ibrutinib to venetoclax, similar patterns emerged when we looked at real-world trials, real-world patient populations outside of the venetoclax clinical trials. So this paper just is the landmark Murano paper that Dr. Mato just presented the longer-term follow-up data from. Again, to remind everyone, this is venetoclax in combination with rituximab in relapsed or refractory CLL. It was given as a time-limited therapy, so 24 months of venetoclax, and a high proportion of patients achieved undetectable minimal residual disease. But importantly, this compared chemoimmunotherapy with bendamustine rituximab to venetoclax and rituximab. So there was no ven monotherapy control arm in this study. And so a question that comes up from this data is, what is the anti-CD20 antibody therapy adding to venetoclax in terms of PFS and OS? And this might even be more relevant as we consider COVID-19 pandemic and vaccination. And so there is a retrospective comparison led by Dr. Mato, a multi-center study, and basically it compared venetoclax alone or in combination with anti-CD20 monoclonal antibody therapy in this relapsed refractory population, and found a similar PFS and OS. Now, they're really looking across subgroups, and this table shows that there really wasn't a subgroup who benefited in the real world setting, this retrospective study with venetoclax in combination with anti-CD20 therapy. And so now we'll shift gears. We've talked about ibrutinib, we've talked about venetoclax, but what about how these agents should be sequenced, and how can real-world evidence guide selection of next therapy for individual patients? So this is a study that looked at the optimal sequencing of ibrutinib, idelalisib, and venetoclax with a large population of patients. And basically it looked at, for particular patient populations, for example, kinase inhibitor intolerant patients, can they be successfully treated with an alternate kinase inhibitor? And then it also looked at, for patients who failed ibrutinib, dividing into the reasons for discontinuation of ibrutinib, intolerance or CLL progression, what is the next best therapy? So these graphs just highlight some of the results. You can see that the PFS for alternate kinase inhibitor really does vary by reason for discontinuation of the first kinase inhibitor. So for patients that discontinue due to toxicity, treatment with an alternate kinase inhibitor really does look to be an option, versus those who progress on a kinase inhibitor had worse PFS. And this is an important on the right here, and it shows that venetoclax might be a better choice in patients who have failed ibrutinib for CLL progression. So this just demonstrates the beginnings of how real-world evidence can develop sequencing strategies, because clinical trials with these agents being developed simultaneously, or by the time the clinical protocols really read out, the control arms are often outdated. This again highlights the progression-free survival following kinase inhibitor discontinuation, looking at the treatment choices, and you'll see venetoclax in red at the top. And so more recently, a problem that has begun to emerge is, how do we treat CLL after discontinuation of venetoclax? And so I think that this is a good question to end on and highlight, because really there's a lack of clinical trial data in this space. And that means that our clinical practice right now is largely informed by real-world evidence while we await the results of randomized clinical trials. And so as more patients are treated with frontline venetoclax based off of the CLL14 model with venetoclax and obinutuzumab, particularly because this is fixed duration, a growing number of patients will require treatment of CLL following discontinuation of venetoclax. Real-world evidence in this setting is extremely important for patients and providers. And so if you look here, there's limited data on this topic. You can see a very small number of patients in the literature. And really the question is, well, for patients who get frontline venetoclax or venetoclax in an earlier line of therapy, can they be treated with ibrutinib after venetoclax? And data addressing this key sequencing question really was a major limitation in supporting a venetoclax to Bruton's tyrosine kinase inhibitor sequence, prompting a real-world analysis. And so here I'm showing a real-world analysis of 326 CLL patients, and really looking at the efficacy of therapies following discontinuation of venetoclax. And so this is a complex table looking at response to therapies after venetoclax, but really just to highlight, there's been the standard options would be BTK inhibitors, PI3 kinase inhibitors, CAR T cells, obviously on a clinical trial, and anti-CD20 antibody therapy. And so you'll see here that overall response rate to ibrutinib was quite high at 84% for the BTK naive patients. So this is a very good option based on this real world analysis. And that for patients who were BTK exposed or BTK resistance, the number is a little bit lower. For PI3 kinase inhibitors, the response is not quite as good, and we'll see in a later slide that it's less durable as well. And these are the curves you can see here. C is the PI3 kinase inhibitors following in venetoclax, which I just highlighted. And then at the top, you'll see that the PFS for BTK naive patients for BTK inhibitor after venetoclax is quite good. But then in graph B, you'll see that those that discontinued for adverse events specifically had an improved PFS. And so just to wrap up and give a This summarizes what we just saw on the previous slide, the overall response rate of 84%. And then venetoclax retreatment, for those who had gotten a fixed duration venetoclax up front, and then had a treatment-free duration remission, there's been some question as whether that could be a strategy as well. And there was data presented at the ASH meeting with follow-up from the Murano data with 18 patients retreated with a response rate of 72%. And we undertook a multi-center real-world retrospective study to look at the same question, and we found the same response rate actually in the same number of patients, 72%. And so this is just one way in which we're answering a question that hasn't yet been answered by clinical trials. Here is just looking at the treatment of CLL after venetoclax discontinuation and highlighting that a lot of the sequencing algorithm that can be found in the ASH meeting education book is derived from real-world evidence. And so in summary, real-world evidence, as we talked about, is collected outside of the controlled environment of randomized clinical trials, and it can be really a powerful complementary source of knowledge in conjunction with randomized clinical trials to fill key knowledge gaps, especially with regards to sequencing of therapies and patients that were excluded from these landmark trials. And really, as we've seen emerge, that this real-world evidence can play a role throughout the life cycle of a drug. It really can generate and be used to test hypotheses, and it can help meet unmet needs for patients, physicians, and the healthcare system. So with that, thank you, and I think we'll switch to taking questions.
Okay, thank you, Dr. Thompson. I'll start with some questions. And my first question is, we used to have an idea that after a BTK inhibitor failure, if the patient progresses, you would go for a BCL2 inhibitor. How does the LOXO 305 changes that scenario? Will you still keep the patient in the same class of the BTK inhibitors, or do you believe we should switch to another class of therapy?
Meg, you want to take that one?
Sure. Yeah, I think it's a really good question. I think, it's important to highlight that LOXO 305 data is still in the clinical trial phase. So it's only, available to patients right now on a clinical trial. So it's certainly not standard, although the efficacy data seen in the phase 1/2 combined trial is really promising. I think that it's, looking at treatment after a BTK inhibitor, I think is all about the reason for the discontinuation of that BTK inhibitor. So I think, for patients who discontinue due to toxicity, there's good data that out to support keeping them in the same drug class. So going from, for instance, ibrutinib to acalabrutinib, Carrie Rogers just reported on a trial of patients that was just published in Hematologica that showed really good clinical efficacy of acalabrutinib as well as tolerability. Looking at, should you go to a BCL2 inhibitor or keep it within the same class now with the emergent non-covalent BTKs, I think that that's really an unanswered question, and we can hypothesize a lot about it. I mean, I think there's scientific rationale to keep someone within the same class of therapy and not really subject their CLL to the pressure, selective pressure of another drug class at first. But we've also seen success with combinations. And so I think, there can be arguments for and against, and we'll really have to, use real world evidence as well as clinical trials to answer that question.
Okay. And what percentage of patients in the US are now being treated in first line with venetoclax? Do you think this is it's growing, the number of patients? And how do you select each patient for each therapy?
I think it is growing for sure. I don't know the actual percentage. Certainly in our practice, it's a pretty commonly used regimen. in the absence of head-to-head comparative data, it's not so easy to make this decision for between BTK inhibitors and VEN. So we weigh the pluses and the minuses of both, the fixed duration, but the complex schedule, the easy start, but the continuous therapy with seemingly more AEs, and try to help patients to make that decision with no clear right answer, and recognizing that most patients, whatever they start with, they'll get the other one somewhere along the line later on.
Okay, and the P53 status, does it help you on selecting the therapy? There's some question about, how fast these patients relapse after stopping therapy with venetoclax.
Not really sure. I was leaning more towards having to use BTK inhibitors for these patients, but I think this is probably one of the best areas where there's tremendous danger for cross-trial comparison. So depending on the time points that you look at, well, first of all, BTK inhibitors are barely studied in del-17p patients anyway, but depending on the time points that you look at, the real world data that Megan presented really showed that the 17p patients were doing less well with BTK-based therapy as well. I tend to think they need more of a continuous therapy. If I give them venetoclax and they're MRD positive at the end of therapy, I would probably continue it. But this is why we need randomized trials specifically in these high-risk patient populations. Otherwise, we're mixing and matching studies, and I think we'll probably come up with the wrong conclusions.
Okay. I'm very impressed by the real world data on discontinuation of ibrutinib. It's really high. Have you guys looked at discontinuation in other BTK inhibitors like acalabrutinib or zanubrutinib?
I guess I could answer that. We barely started to look at acalabrutinib and haven't really pursued it very much. Zanubrutinib, not at all, because it's not approved. So we haven't done much work there.
Okay. And do you already have approval for combination in first-line or relapse disease?
Of BCL2 and inhibitor?
Yeah.
No.
Okay. So for a patient that is relapsed after a BTK inhibitor, you would go for venetoclax, right? And would you consider cellular therapy for these patients in, CAR-T or allogeneic transplant? And when would you consider that?
Meg, you want to take that one?
So yes, cellular therapy, but only available on a clinical trial, so not always available to patient. I mean, I guess if you're looking at a patient who's gotten BTK inhibitor and BCL2 inhibitor, the standard options available really are PI3 kinase inhibitors, which we saw from the real world data have, a response rate of, upper 40%, but the median duration of response was about 5 months, so not durable. So I do think that cellular therapy, if available on a clinical trial, is an option. In terms of the role of transplant, less commonly used given how efficacious these agents are, but for a very young patient, it is something that we do talk about in the clinic if we have a patient who's double refractory to both classes of agents, and then the goal would be to get them into a response good enough to take them to a transplant or other cellular therapy on a clinical trial.
Okay. Regarding the Richter transformation, the data you presented, Dr. Mato, was very impressive. But of course, this is not standard of care in your institution. What do you usually do for Richter's transformation as a standard of care in Memorial Sloan Kettering?
Good question. Newly diagnosed Richter's transformation, we generally give them, if there's not a clinical trial option for them, which is what we advocate for, chemoimmunotherapy and try to combine it with venetoclax. The R-EPOCH Ven data seem impressive, of course, not randomized, but we do that a fair amount.
Okay. Let me see if I have some questions from the chat. There's one question regarding treatment of fit patients that are asymptomatic. Do you have any scenario that would you consider treating an asymptomatic patient with CLL outside of a clinical trial?
Meg, you want to take that one?
Yeah, so I mean, the answer really is no. You know, if they don't meet any of the other IWCLL criteria for initiation of therapy at this time, we don't have any data to support, you know, initiation of therapy. So we really do go by the IWCLL.
Okay. I also have another question on how to choose between all the BTK inhibitors. What do you usually use to guide between ibrutinib or acalabrutinib in first line or in relapsed disease?
Very loaded question. Comfort level, what patient populations they were studied in, some extrapolation from cross-trial comparison. We're waiting for the head-to-head data to be presented someday, which I think would be helpful in making a decision about efficacy as well as tolerability. So right now, I can't cite any strong data source that says you have to use one over the other. And so I think it's patient and provider preference, and then thinking about some of the minor nuances between the drugs, twice a day versus once a day, PPI interactions, maybe some slight differences in AE profiles.
Okay, and what about the addition of anti-CD20 in first line when using a BTK inhibitor?
Certainly rituximab is out.
Okay.
With ibrutinib, I wouldn't, because there's no randomized data. With acala, it's tempting based on the Elevate TN trial, but we need longer term follow-up.
Okay. So we have another question regarding outside clinical trials in your daily practice. How do you do the MRD testing and how often do you usually do it?
Meg, you want to take that one?
Sure. So I guess it should be said that outside of clinical trials, MRD testing really isn't, you know, standard of care at all to guide clinical decisions. We do have the capacity at our center to do it in our clinic, and so we can check it, but it's really not standard of care. I mean, Dr. Mato mentioned some circumstances where the data is suggestive, and we have some ongoing trials to really validate these hypotheses, specifically the TP53 aberrant patients with the fixed duration of venetoclax. You know, if they're MRD positive at the end of therapy, we'd have a discussion about continuing venetoclax in those patients, but really need more data on it.
And you usually do it by flow cytometry and blood or bone marrow?
Yeah, good question. So I think it really probably is center dependent on what's available, because everyone has something different. You know, we have the capacity to do flow cytometry in-house here, typically do it on the blood out, you know, if it would be, you know, both on and off clinical trial. I think subjecting a patient for a bone marrow without, you know, good data to support its use yet is probably not the best idea at this time. And then there, you know, are other sequencing assays that can be used to do it as well. And so I think these are unanswered questions.
Okay. Dr. Mato, people are asking you to comment on the venetoclax continuation if patient is MRD positive. Have you seen patients responding after 12 cycles with continuous therapy on venetoclax?
Personally, no, but I don't have a large enough group of patients yet to comment on that. What I do think is that even if the depth of remission doesn't improve, maybe the rate of progression may be slower. And like I said, our frontline clinical trial we have right now for patients getting venetoclax who are MRD positive at the end of therapy, they continue on venetoclax for another year to try to improve those outcomes. So I can't cite a large data set, but you saw the data from CLL14 where 50% of those patients had deepening of remission towards the end of therapy. So it makes sense to me that there's nothing magical about 12 months.
Okay. I think, let me see if we have more questions here. Let me see. Let me see if I have another question. Would you like to comment on the COVID data you had on real-world data with CLL and the outcomes of patients during the COVID-19? Sure. Yeah.
We did a large multi-center, you participated, look at case fatality rates early on in the pandemic and found a pretty high death rate in CLL in largely hospitalized patients. It got a lot of attention. Not a huge surprise that immunocompromised patients would do worse. We are updating those data and hopefully publishing soon to say with longer longer follow-up during this pandemic that patients are probably doing better, maybe due to some of the therapeutic interventions. So early on, CLL patients had a dismal outcome. Our data, Spanish data, ERIC data all found the same thing, but maybe things are getting better. So hopefully we can update that data.
Okay. There's one last question here. What is the percentage of patients that you still give chemotherapy in your daily practice? Do you have these patients? I mean, FCR is still on the, in the guidelines, but do you usually do it in your daily practice?
Almost zero.
Okay.
Usually not. Usually we still talk about it, but very, very rarely use it.
Okay. That's what I imagine.
And, Guilherme, we can always, Megan presented the real world data that's made a huge impact in CLL. So hopefully you can organize colleagues in Brazil and we can continue to try to answer questions together. We'll definitely be in touch with you when we have our next question to try to address these important questions for CLL.
Okay. Thank you so much, Dr. Mato and Dr. Thompson. The real world data is very important for us in countries where clinical trials are not, routinely used. So thank you again for this amazing work. And thank you for having this time with us. Então, pessoal, com isso eu vou terminar aqui o nosso encontro. Mais uma vez agradecendo o Dr. Mato e a Dr. Thompson. Foi muito interessante ver não só as novidades, mas também os dados de mundo real. Com isso, agora a gente vai chamar um vídeo da Abbvie e conto com vocês nos próximos encontros que a gente tiver pela ABHH. Muito obrigado, pessoal. Grande abraço.